Welcome to this video entitled Parasitic Diseases. We will begin by looking at a few key concepts. 1. Parasites normally inflict some degree of injury to the host, the extent of which depends on such factors as parasite load, nutritional status, and immunologic competence of the host. 2. The primary reasons for deaths due to malaria are failure to take chemoprophylaxis, inappropriate chemoprophylaxis, delay in seeking medical care, and misdiagnosis. 3. In adults, including pregnant women, the chemoprophylaxis for all species of Plasmodia is chloroquine phosphate 300 mg base, once weekly beginning 1 week prior to departure and continuing for 4 weeks after leaving an endemic area. 4. In an uncomplicated attack of malaria, for all Plasmodia except chloroquine-resistant Plasmodium falciparum, the recommended regimen is chloroquine 600 mg base initially, followed by 300 mg base 6 hours later, and then 300 mg base daily for 2 days. 5. Because falciparum malaria is associated with serious complications including pulmonary edema, hypoglycemia, jaundice, renal failure, confusion, delirium, seizures, coma, and death, careful monitoring of fluid status and hemodynamic parameters is mandatory. 6. Intestinal amoebiasis is diagnosed by demonstrating entamoeba histolytica cysts or trophozoites may contain ingested erythrocytes in fresh stool or from a specimen obtained by sigmoidoscopy. 3 stool samples obtained 24 hours apart will produce a 60% to 90% yield for entamoeba histolytica. 7. All symptomatic adults and children older than 8 years of age with giardiasis should be treated with metronidazole 250 mg 3 times daily for 7 days. 8. In the adult, both the cutaneous and mucocutaneous forms of leishmaniasis, Leishmania brasiliensis and Leishmania mexicana, are treated with stibogluconate. An alternative drug for the visceral form is amphotericin B9. In chronic trypanosomiasis, Chagas disease, patients present with cardiomyopathy and heart failure. 10. The agents used commonly for the treatment of enterobiasis include pyrantyl pamoate, mebendazole, or albendazole. 11. The resistance of lice to permethrin is increasing, and 0.5% malathion is an effective alternative. Parasitic diseases are receiving increasing attention from clinicians in the United States because of the high frequency of travel, deployment of personnel for humanitarian and military missions, e.g., Peace Corps volunteers, inflow of immigrants from a wider geographic distribution, and the presence of immunosuppressed populations, e.g., AIDS and transplant patients. Migrant farm workers who work and live in substandard hygienic conditions, the large and growing Central and South American immigrant population, and other poorly screened immigrants from Asia represent significant sources of parasitic infections in the United States. Clinicians need to have a heightened awareness for parasitic diseases and how to treat them. Clinical signs and symptoms, together with the patient's travel history, should be used with other diagnostic aids in the identification of parasitic diseases. Parasitic infections caused by pathogenic protozoa or helminths affect more than 3 billion people worldwide and impose tremendous health and economic burdens on developing countries. This chapter discusses the major parasitic diseases, including protozoan diseases e.g. amoebiasis, or malaria, helminthic infections e.g. ascariasis, or enterobiasis, and ectoparasitic infestations e.g. head and body lice. Emphasis is placed on diseases seen more frequently in the United States. World distribution of parasites depends on the presence of suitable hosts, habitats, and environmental conditions. A human parasite that does not use an intermediate host is likely to be found in any inhabited region of the world as long as the environmental conditions are suitable. Ascaris, that is roundworm, and trichoris, that is whipworm, require carelessness of habits for transfer and require time outside the body, where they are exposed to heat and dryness, to reach the infective stage. The distribution of the hookworm is more limited because the free-living forms are unprotected by resistant shells or cysts. African trypanosomiasis never occurs outside the range of the tsetse fly, malaria never occurs beyond the range of the infective Anopheles mosquito, and schistosomiasis never occurs in the absence of a specific water snail. The prevalence of clonorchiasis, that is the Chinese liver fluke, is an example of the impact of both environmental and geographic factors. Clonorchiasis requires the simultaneous presence of not only humans, specific snail species, and certain fish but also unsanitary conditions that make the eggs accessible to the snails, an association of the snail and fish, and the established local habit of eating raw fish. The ability of some parasites to infect hosts other than humans may perpetuate an infection even when human habits preclude the possibility of more than occasional access to the human body. In North America, the broad tapeworm, also called Diphyllobothrium latus, would perish if it were not that dogs and other carnivores, such as the brown bear, serve as reservoir hosts. Next we will discuss host-parasite relationship. Symbiosis is the association of two species for the purpose of obtaining food for either one or the other. Parasitism is a symbiotic relationship in which one species, the host, is injured through the activities of the other. Through evolution, parasites have made specific morphologic adaptations. Adaptation to the host has taken a number of forms: loss of locomotor organelles in the protozoa and sporozoa, partial and complete lack of digestive systems in the trematodes and cestodes, respectively, elaboration of proteolytic enzymes to penetrate the host intestinal mucosa by Entamoeba histolytica, the cercariae of the blood fluke that penetrate the skin of the host by elaborate enzymes, and finally, the ability to infect an intermediate host to increase reproductive capacity, as seen among the cestodes and trematodes. Parasites normally inflict some degree of injury to the host, the extent of which depends on such factors as parasite load, nutritional status, and immunologic competence of the host. Entamoeba coli is considered commensal because it subsists on the bacterial flora of the gut and does not cause any harm to the host. Unlike Entamoeba coli, Fasciolopsis busci, the giant intestinal fluke, can produce severe local damage to the intestinal wall. Ascaris, the roundworm, can perforate the bowel wall, cause intestinal obstruction, and invade the appendix and bile duct. Malarial parasites destroy red cells by multiplying inside them. Diphyllobothrium latum, or the broad fish tapeworm, removes vitamin B12 from the gastrointestinal tract, resulting in megaloblastic anemia. Next we will discuss protozoan diseases. Let's begin with malaria. Malaria represents the most devastating disease in terms of human suffering and economics. It affects the largest number of people. Between 300 and 500 million new infections are reported annually in the world, with more than 2 million deaths worldwide. In the United States, deaths from malaria are preventable. The primary reasons for deaths are failure to take chemoprophylaxis, inappropriate chemoprophylaxis, delay in seeking medical care, and misdiagnosis. Next we will discuss the epidemiology of malaria. The exact geographic distribution of the various species is not well documented, however, it is reported that Plasmodium vivax is more prevalent in India, Pakistan, Bangladesh, Sri Lanka, and Central America, whereas Plasmodium falciparum is predominant in Africa, Haiti, Dominican Republic, the Amazon region of South America, and New Guinea. Both Plasmodium falciparum and Plasmodium vivax are prevalent in all of Southeast Asia, South America, Middle East, North Africa, Ethiopia, Somalia, and Sudan. Most of the infections with Plasmodium ovale occur in Africa, and the distribution of Plasmodium malariae is considered worldwide. In the United States, most cases of malaria are reported in immigrants from endemic areas and in American travelers. Blood transfusion also has been cited as a cause of malarial infection. The transmission of malaria from recent immigrants from endemic areas is a real threat because of the presence of a number of mosquito vectors, Anopheles quadrimaculatatus and Anopheles punctipennis in the United States. Next we will discuss the etiology of malaria. Malaria is transmitted by the bite of an infected Anopheles mosquito that introduces the sporozoites, tissue parasites, of the Plasmodia, Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae, and Plasmodium ovale, into the bloodstream. The asexual reproduction stage develops in humans, whereas the sexual stage occurs in the mosquito. The sporozoites invade parenchymal hepatocytes, multiply in stages referred to as exoerythrocytic stages, and become hepatic vegetative forms or schizonts. Schizonts rupture to release daughter cells, or merozoites, that then infect erythrocytes. Plasmodium falciparum and Plasmodium malariae remain in the primary exoerythrocytic stage in the liver for about 4 weeks before invading erythrocytes, whereas Plasmodium vivax and Plasmodium ovale can exist in the liver in the latent exoerythrocytic form for extended periods, and therefore, infected subjects can experience relapses. The merozoites that invade the erythrocytes develop sequentially into ring forms, trophozoites, schizonts, and finally, merozoites, which can invade other erythrocytes or can develop into gametocytes, which undergo the sexual stage in the Anopheles vector. Erythrocytic forms never reinvade the liver without developing into sporozoites in the vector, and therefore, malaria infections from transfusion never result in the exoerythrocytic, or liver, form. Plasmodium falciparum can result in high levels of parasitemia because of its ability to invade erythrocytes of all ages, unlike Plasmodium vivax and Plasmodium ovale, which only invade young cells. Pause the video and carefully scrutinize Table 113.1 summarizing clinical presentation of malaria before advancing to the next slide. We will now look at the pathology of malaria. The erythrocytic phase causes extensive hemolysis, which results in anemia and splenomegaly. The most serious complications usually are associated with Plasmodium falciparum infections. Infants and children younger than 5 years of age and non-immune women who are pregnant are at high risk for severe complications from falciparum malaria. The complications associated with falciparum malaria are primarily a result of the high parasitemia and the ability of the parasites to sequester in capillaries and post-capillary vessels of organs such as the brain and the kidney. It has been postulated that tissue hypoxia from anemia, together with Plasmodium falciparum parasitized red blood cell adherence to endothelial cells in capillaries, contributes to extensive vascular disease and severe metabolic effects. Plasmodium malariae is implicated in immune-mediated glomerulonephritis and nephrotic syndrome, as shown in Table 113.1. To ensure a positive diagnosis, blood smears should be obtained every 12 to 24 hours for 3 consecutive days. The presence of parasites in the blood 3 to 5 days after initiation of therapy suggests drug resistance. Recent advances for detecting malaria parasite have included DNA or RNA probes by polymerase chain reaction (PCR) and a rapid dipstick test (PARASIGHTF). Becton Dickinson, Cockeysville, MD. The dipstick is reported to have a sensitivity of 88% and a specificity of 97%, which is comparable with microscopy. Next we will discuss the treatment of malaria. Let's begin with the desired outcome. The primary goal in the management of malaria is the rapid diagnosis of the Plasmodia species by blood smears, repeated every 12 hours for 3 days, so as to initiate timely anti-malarial therapy to eradicate the infection within 48 to 72 hours and to avoid complications such as hypoglycemia, pulmonary edema, and renal failure that are responsible for increased mortality in malaria. Next we will discuss the pharmacologic therapy. In adults, including pregnant women, the chemoprophylaxis for all species of Plasmodium is chloroquine phosphate 300 mg base, once weekly beginning 1 week prior to departure and continued for 4 weeks after leaving an endemic area. The pediatric dose of chloroquine phosphate is 5 mg base per kilogram of body weight, maximum 300 mg. When visiting or leaving an area endemic for Plasmodium vivax or Plasmodium ovale, primaquine phosphate, equivalent to primaquine, 15 mg base, daily for 14 days beginning the last 2 weeks of chloroquine prophylaxis should be added to the regimen. The pediatric dose of primaquine is 0.3 mg base per kilogram of body weight per day for 14 days. The pediatric doses of chloroquine can be calculated based on body weight, and the tablets can be pulverized and placed in gelatin capsules. Parents can be instructed to suspend the dose in food, simple syrup, chocolate milk, or drink. In areas where chloroquine-resistant Plasmodium falciparum strains exist, travelers should receive mefloquine, marketed as Lariam, for prophylaxis. The adult dose of mefloquine is 250 mg once weekly beginning 1 week prior to departure and continuing for the full period of exposure, followed by 250 mg for 4 weeks after last exposure. The pediatric dose of mefloquine for prophylaxis is as shown in the white box below. Pause the video and carefully scrutinize the white box before advancing to the next slide. In travelers who are at immediate risk for drug-resistant falciparum malaria, a loading dose of mefloquine may be considered. Mefloquine is administered at 250 mg daily for 3 days before travel, followed by 250 mg once weekly while in the endemic area and continued for 4 weeks after last exposure. Some patients may experience neuropsychiatric reactions from this regimen and may need to be monitored closely. An alternative regimen for prophylaxis in chloroquine-resistant areas for those who cannot tolerate mefloquine is to take doxycycline 100 mg daily starting 1 to 2 days prior to departure, during the exposure period, and continuing for 4 weeks after leaving the endemic area. Children older than 8 years of age should receive 2 mg per kilogram per day up to 100 mg of doxycycline. Doxycycline is contraindicated in children younger than 8 years of age, in pregnant women, and during breastfeeding. Another alternative regimen for chemoprophylaxis is the combination of atovaquone and proguanil, marketed as Malarone, 1 tablet daily beginning 1 to 2 days prior to travel and continuing for the duration of stay and 1 week after leaving the area. Daily primaquine 15 mg base also has been recommended for prophylaxis for both Plasmodium vivax and Plasmodium falciparum malaria. In an uncomplicated attack of malaria, for all Plasmodia except chloroquine-resistant Plasmodium falciparum, the recommended regimen is chloroquine 600 mg base initially, followed by 300 mg base 6 hours later, and then 300 mg base daily for 2 days. In severe illness or when oral therapy is not tolerated or parenteral quinine is not available, quinidine gluconate 10 mg per kilogram as a loading dose, maximum 600 mg, in 250 ml normal saline should be administered slowly over 1 to 2 hours, followed by continuous infusion of 0.02 mg per kilogram per minute until oral therapy can be started. In patients who have received either quinine or mefloquine, the loading dose of quinidine should be omitted. Oral quinine 300 mg every 8 hours should follow the intravenous dose of quinidine to complete 3 days for all infections, except for Plasmodium falciparum acquired in Thailand, in which case a full 7-day course should be given. The pediatric dose of intravenous quinidine gluconate is the same as the dose for adults. The pediatric dose of quinine is 25 mg per kilogram per day in 3 divided doses for 3 or 7 days. In Plasmodium falciparum chloroquine-resistant infections, a dose of 750 mg mefloquine followed by 500 mg 12 hours later is recommended. The pediatric dose of mefloquine is 15 mg per kilogram, less than 45 kg, followed by 10 mg per kilogram 8 to 12 hours later. Intravenous quinidine gluconate followed by oral quinine should be administered for severe illness, as already indicated. A second drug needs to be administered in chloroquine-resistant Plasmodium falciparum, and this second drug should follow the oral quinidine regimen, either a single dose of 3 tablets of pyrimethamine sulfadoxine, marketed as Fansidar, on the last day of intravenous quinidine or clindamycin 900 mg 3 times daily for 3 to 5 days. An alternative oral treatment for chloroquine-resistant Plasmodium falciparum infection in adults, especially in those with a history of seizures or psychiatric disorders, is the combination of atovaquone 250 mg and proguanil 100 mg, Malarone, 4 tablets daily for 3 days. The intravenous quinidine regimen requires close monitoring of the electrocardiogram and other vital signs, e.g., hypotension and hypoglycemia. Because falciparum malaria is associated with serious complications, including pulmonary edema, hypoglycemia, jaundice, renal failure, confusion, delirium, seizures, coma, and death, careful monitoring of fluid status and hemodynamic parameters is mandatory. Exchange transfusion that may be required in patients with Plasmodium falciparum malaria in whom parasitmia is 5% to 15% remain a questionable modality. Either peritoneal or hemodialysis may be indicated in renal failure. Malarial infection does not produce immunity in patients, and active research has been initiated to develop a malaria vaccine. A vaccine that blocks the entry of sporozoites into the liver cells will prevent malaria at this stage. However, immunity to sporozoites does not protect the host against parasites in the erythrocytic cycle. Infective sporozoites of Plasmodium falciparum are covered by a polypeptide, circumsporozoite protein. Isolation and identification of the gene encoding for this circumsporozoite protein have led to the development of a monoclonal antibody by recombinant DNA technology. Plasmodium falciparum sporozoite vaccine is now under investigation. We will now discuss evaluation of therapeutic outcomes. When advising potential travelers on prophylaxis for malaria, be aware of the incidence of chloroquine-resistant Plasmodium falciparum malaria and the countries where this is prevalent. Detailed recommendations for prevention of malaria may be obtained by checking the World Wide Web, e.g., www.cdc.gov/travel/ or www.cdc.gov/mmwr/, or by calling the Centers for Disease Control and Prevention (CDC). See Appendix 113-1. A number of newer drugs are under active study and include the water-soluble artesunate and the oil-soluble artemether, lumefantrine, also known as benflumetol, and combinations of this with other agents, and the recently approval combination atovaquone and proguanil, marketed as Malarone, in the United States. Halifentrine, marketed as Halfan, has poor bioavailability, prolongs the QTc interval at the recommended doses, and has been reported to have therapeutic failures. Acute Plasmodium falciparum malaria resistant to chloroquine should be treated with intravenous quinidine. These patients should have a central venous catheter to follow fluid status, and the electrocardiogram should be monitored closely. Hypoglycemia that is associated with Plasmodium falciparum should be checked and corrected with dextrose infusions. Quinidine infusion should be slowed temporarily or stopped if there is a QT interval of greater than 0.6 second, an increase in the QRS complex to greater than 50%, or hypotension unresponsive to fluid challenge results. The suggested quinidine levels should be maintained at 3 to 7 mg per liter. Blood smears should be checked every 12 hours until parasitemia is less than 1%. Resolution of fever should take place between 36 and 48 hours after initiation of the intravenous quinidine therapy, and the blood should be clear of parasites in 5 days. If parenteral therapy is required for more than 48 hours, it is suggested that the dose of quinidine be lowered by half. Travelers to endemic areas for malaria should be advised to remain in well-screened areas, to wear clothes that cover most of the body, and to sleep in mosquito nets. It is prudent to carry the insect repellent DEET N,N-diethylmethatoluamide, or other insect sprays containing N,N-diethylmethatoluamide, for use in mosquito-infested areas. Readers are urged to check publications from the CDC for the list of countries where chloroquine-resistant Plasmodium falciparum exist. Next we will discuss amoebiasis. Let's begin with epidemiology and etiology. Because of its worldwide distribution and serious gastrointestinal manifestations, amoebiasis is one of the most important parasitic diseases of humans. The major causative organism in amoebiasis is Entamoeba histolytica, which inhabits the colon and must be differentiated from the Entamoeba dispa, which is associated with an asymptomatic carrier state and is considered nonpathogenic. Although Entamoeba histolytica and Entamoeba dispa are indistinguishable morphologically, recent research using monoclonal antibodies has been able to separate the two. Invasive amoebiasis is almost exclusively the result of Entamoeba histolytica infection. Approximately 50 million cases of invasive disease result each year worldwide, leading to an excess of 100,000 deaths. In the United States, the incidence of amoebiasis is estimated at about 4% in the general population. The highest incidence is found in institutionalized mentally retarded patients, sexually active homosexuals, patients with acquired immune deficiency syndrome (AIDS), the Native American population, and new immigrants from endemic areas e.g., Mexico, India, West and South Africa, and portions of Central and South America. Next we will discuss the pathology of amoebiasis. Entamoeba histolytica invades mucosal cells of colonic epithelium, producing the classic flask-shaped ulcer in the submucosa. The trophozoites has a cytolethal effect on cells through a toxin. If the trophozoites gets into the portal circulation, it will be carried to the liver, where it produces abscess and periportal fibrosis. Amoebic ulcerations can affect the perineum and genitalia, and abscesses may occur in the lung and brain. Next we will discuss the clinical presentation of amoebiasis. The most frequent clinical manifestations of the disease are gastrointestinal, as shown in Table 113-2. Liver abscesses that are located in the right lobe can spread to the lungs and pleura. Pericardial infection, although rare, may be associated with extension of the amoebic abscess from the left lobe of the liver. Erosion of liver abscesses also present as peritonitis. Review of the patient's history and recent travel cannot be overemphasized. Intestinal amoebiasis is diagnosed by demonstrating intemba histolytica cysts or trophozoites may contain ingested erythrocytes in fresh stool or from a specimen obtained by sigmoidoscopy. 3 stool samples obtained 24 hours apart will produce a 60% to 90% yield for intemba histolytica. Microscopy may not differentiate between the pathogenic intemba histolytica and the non-pathogenic intemba dispa in stools. Sensitive techniques are available to detect intemba histolytica in stool, including antigen detection and PCR. Endoscopy with scraping or biopsy may provide more definitive diagnosis where stool examinations do not provide adequate evidence. When amoebic liver abscess is suspected from initial physical examination and history, confirmatory diagnostic procedures will include serology and liver scans, using isotopes by ultrasound or computed tomography, or magnetic resonance imaging. Leukocytosis greater than 10,000 per millimeter cubed, and an elevated alkaline phosphatase concentration greater than 75% are common findings. In rare instances, needle aspiration of the hepatic abscess may be attempted using ultrasound guidance. Pause the video and carefully scrutinize Table 113-2 summarizing most common manifestations of amoebiasis before advancing to the next slide. Next we will discuss the treatment of amoebiasis. Let's begin with the desired outcome in amoebiasis. The goals of therapy are initially to eradicate the parasite by use of specific amoebicides and then to render supportive therapy. Next we will discuss treatment regimens. A number of different regimens have been suggested depending on the category of amoebiasis: asymptomatic cyst passes, intestinal amoebiasis, and amoebic liver abscess. Electrolyte replacement and nutritional support are essential adjunctive treatment modalities. Large hepatic abscess or amoebic pericarditis may require needle aspiration, percutaneous catheter drainage, or rarely, surgery before drug therapy. Most regimens require a combination of drugs administered concurrently or sequentially. A careful history should be taken when one of the differential diagnoses is ulcerative colitis because corticosteroid administration has the potential to unmask amoebiasis and produce toxic megacolon. All patients diagnosed as having inflammatory bowel disease should have their stools examined carefully and serologic testing done for amoebiasis to avoid the serious consequence that results from the administration of corticosteroids. We will now discuss pharmacologic therapy. Metronidazole, marketed as Flagyl, tetracycline, dihydroemetine, and chloroquine, marketed as Aralen, are tissue-acting agents, whereas iodiquinol, marketed as Iodoxin, diloxanide furoate, marketed as furamide, and paramomycin, marketed as Humatin, are luminal amoebicides. A systemic agent may be so well absorbed that only small amounts of the drug stay in the bowel, which might prove ineffective as a luminal agent. A luminal acting agent, on the other hand, may be too poorly absorbed to be effective in the tissue. In the asymptomatic cyst passer, it is necessary to eradicate the causative agent from the lumen to prevent intestinal amoebiasis or the development of amoebic liver abscess. Drug effectiveness must be monitored by stool examination, i.e., from 1 to 3 negative specimens from 1 to 3 months after treatment. Asymptomatic cyst passers and patients with mild intestinal amoebiasis should receive one of the following luminal agents: paramomycin 25 to 30 mg per kilogram per day 3 times daily for 7 days, iodiquinol 650 mg 3 times daily for 20 days, or diloxanide furoate 500 mg 3 times daily for 10 days. These regimens have cure rates of between 84% and 96%. Diloxanide furoate is only available from Panorama Compounding Pharmacy, 6744 Balboa Boulevard, Van Nuys, California, 91406-800-247-9767. The pediatric dose for paramomycin is the same as in adults, whereas the dose of iodiquinol is 30 to 40 mg per kilogram per day in 3 doses for 20 days, and the dose of diloxanide furoate is 20 mg per kilogram per day in 3 doses for 10 days. Paramomycin is the preferred luminal agent in pregnant patients. Patients with severe intestinal disease or liver abscess should receive metronidazole 750 mg 3 times daily for 10 days, followed by a course of one of the luminal agents indicated earlier. An alternative regimen of metronidazole 2.4 grams per day for 2 days has been suggested to treat intestinal amoebiasis. In the pediatric patient, the dose of oral metronidazole is 50 mg per kilogram per day in divided doses to be followed by a luminal agent. Patients who are too ill to take oral metronidazole should receive the drug in equivalent doses by the intravenous route. We will now look at the evaluation of therapeutic outcomes. Follow-up in patients with amoebiasis should include repeat stool examination, serology, colonoscopy in colitis, or computed tomography (CT) in liver abscess between days 5 and 7 at the end of the course of therapy, and a month after the end of therapy. Most patients with either intestinal amoebiasis or colitis will respond in 3 to 5 days with amelioration of symptoms. Patients with liver abscesses may take from 7 to 10 days to respond. Patients not responding during this period may require aspiration of abscesses or exploratory laparotomy. Serial liver scans have demonstrated healing of liver abscesses over 4 to 8 months after adequate therapy. Next, we will briefly talk about sanitation and preventive measures. Travelers and tourists visiting an epidemic area should avoid local tap water, ice, salads, and unpeeled fruits. Water can be disinfected by the use of iodine, tincture of iodine, or commercial sources, potable aqua tablet, Wisconsin Pharmacol, or Globaline, Wallace and Trinane, or a strong chlorine, laundry bleach solution, but boiled water is probably the safest. An alternative or additional measure may be to carry a portable water purifier, SafeWater, Durango, CO, www.outgear.com. Because food handlers in Asia and Latin America may be a source of amoebiasis, travelers should avoid eating at food stalls and open markets. Next, we will discuss giardiasis. Let's begin with its epidemiology and etiology. Giardia lamblia, also known as Giardia intestinalis or Giardia duodenalis, an enteric protozoan, is the most common intestinal parasite responsible for diarrheal syndromes throughout the world. Giardia is the most frequently identified intestinal parasite in the United States, with a prevalence rate of 16% in some areas. Giardia lamblia has been identified as the first enteric pathogen seen in children in developing countries, with prevalence rates between 15% and 30%. There are 2 stages in the life cycle of Giardia lamblia, the trophozoite and the cyst. Giardia lamblia, which is found in the small intestine, the gallbladder, and biliary drainage, is a pear-shaped trophozoite with 4 pairs of flagella. 2 nuclei lie in the area of the sucking disc, giving the protozoan a characteristic face-like image. The distribution of giardiasis is worldwide. Children seem to be affected more frequently than adults. Children in daycare centers may infect parents and other family members. In less developed countries, fecal contamination of the environment and lack of potable water, education, and housing continue to be risk factors for giardiasis among children. Pause the video and carefully scrutinize Table 113.3 summarizing clinical presentation of giardiasis before advancing to the next slide. Next we will discuss the pathology of giardiasis. Giardiasis results from ingestion of Giardia lamblia cysts in fecally contaminated water or food. The protozoan exists under the stimulus of low gastric pH to release the trophozoa T. Colonization and multiplication of the trophozoa T lead to mucosal invasion, localized edema, and flattening of the villi, resulting in malabsorption states in the host. Lactose intolerance precipitated by giardiasis can persist even after eradication of the protozoan. Bichlorhydria, hypogammaglobulinemia, or deficiency in secretory immunoglobulin A, abbreviated as IgA, are predispositions for giardiasis, as shown in Table 113.3. Diagnosis of giardiasis is made by examination of fresh stool or a preserved specimen during the acute diarrheal phase. Fresh stool specimens may show the trophozoites, whereas preserved specimens usually yield the cysts. If both the stool examination and string test prove unsuccessful, it may be necessary to attempt duodenal aspiration and biopsy to confirm the diagnosis. This may be more important in AIDS patients and in patients with hypogammaglobulinemia. Most clinicians would advocate a clinical trial of the standard therapy before undertaking invasive diagnostic tests. An indirect fluorescent antibody, abbreviated as IFA, test that uses a monoclonal antibody to a protein in Giardia cysts is available commercially for the detection of the Giardia antigen. Meridan Diagnostics, Cincinnati, Ohio. Next we will discuss the treatment of giardiasis. Let's begin with the desired outcome. To reduce morbidity and to avoid complications in patients identified with prolonged diarrhea and malabsorption and who have a recent history of travel to an endemic area, rapid identification by ova and parasite, abbreviated as O and P, examination or by antigen detection test should be used to institute appropriate therapy. Next we will discuss pharmacologic therapy. All symptomatic adults and children older than 8 years of age should be treated with metronidazole 250 mg 3 times daily for 7 days. The alternative drugs include furosemide 100 mg 4 times or paramomycin 25 to 30 mg per kilogram per day in divided doses daily for 1 week. Paramomycin 25 to 30 mg per kilogram per day in 3 doses for 7 days or bacitracin or bacitracin zinc may be safe agents in pregnancy. The pediatric dose for metronidazole is 15 mg per kilogram per day 3 times daily for 5 to 7 days. Furosemide suspension 6 mg per kilogram per day in 4 doses for 7 to 10 days and nitazoxanide Alenia suspension, a recently approved agent, 100 to 200 mg every 12 hours for 3 days are alternative drugs for children. Quinacrine, which was the drug of choice in giardiasis, has been discontinued by the manufacturer but is obtained in the United States from a specialized pharmacy. See Appendix 113-1. Albendazole 400 mg daily for 5 days has been cited to produce cure rates of 97% and as being equivalent to metronidazole in children. However, other investigators have disputed the efficacy of this agent. We will now discuss the evaluation of therapeutic outcomes. Patients with symptomatic giardiasis, positive stool samples, or the detection of Giardia antigen by IFA or enzyme-linked immunosorbent assay, abbreviated as ELISA, should be treated with metronidazole for 7 days. Metronidazole produces cure rates of between 85% and 95%. Diarrhea will stop within a few days, although in some patients it may take 1 to 2 weeks. Cyst excretion will cease within days. However, intestinal dysfunction, manifested as increased transit time, and radiologic changes, irregular thickening of the folds in the upper small intestine, may take a few months to resolve. Patients who fail initial therapy with metronidazole should receive a second course of therapy. Pregnant patients can receive paramomycin 25 to 30 mg per kilogram per day in divided doses for 7 days. Metronidazole has been used in the second and third trimesters of pregnancy. Giardiasis can be prevented by good personal hygiene and by caution in food and drink consumption. Preventive measures are similar to those discussed under amoebiasis. See sanitation and preventive measures. Next we will discuss leishmaniasis. Let's begin with its epidemiology and etiology. This disease is caused by a protozoan belonging to the genus Leishmania. The three variations of the disease are visceral leishmaniasis, kala azar, black fever, or Assam fever, cutaneous leishmaniasis, and mucocutaneous leishmaniasis. The visceral form is caused predominantly by Leishmania donovani, whereas the other two forms are caused by other species. Leishmaniasis is a complex disease, but space constraints do not justify an extended discussion here. Interested readers are urged to consult other sources. Leishmania exists in two forms, as a flagellated extracellular parasite in the sandfly vector, also known as phlebotomus in the Indian subcontinent, and Lutsamia and Psychodopygus in North and South America, Africa, or the Middle East, and an aflagella amastigote, that is the intracellular form, in the host. The major reservoirs for Leishmania, depending on geographic location, are dogs, foxes, squirrels, and rodents. The sandflies ingest the parasite when they feed on the reservoir animals. After metamorphosis in the gut of the sandfly, the parasite is transferred to the human host when the infected sandfly takes a blood meal. Cutaneous leishmaniasis, seen most frequently in the United States, is caused by either Leishmania brasiliensis or Leishmania mexicana, which are endemic to South Mexico and Central America. The disease can range from cutaneous ulcers to the mucocutaneous form affecting the nose, oral cavity, and pharynx. The highest incidence usually is seen in the summer months, especially in subjects working near forested areas. Visceral leishmaniasis may be acquired from transfusion of contaminated blood and accidental needle stick injuries. Patients with advanced stage acquired immunodeficiency syndrome (AIDS) are reported to be highly susceptible to leishmaniasis, as shown in Table 113.4. Demonstration of amastigote in tissue or bone marrow confirms the diagnosis of leishmaniasis. Pause the video and carefully scrutinize Table 113.4 summarizing clinical manifestation of leishmaniasis before advancing to the next slide. Next we will discuss the treatment of leishmaniasis. Let's begin with its desired outcome. The major goal is to eradicate the amastigote in the tissue and to minimize the ensuing complications of leishmaniasis. We will now look at pharmacologic therapy. All three forms of leishmaniasis are treated with stibogluconate sodium, that is antimony sodium gluconate pentavalent antimony, pentastam, which is obtained from the CDC. In adults, both the cutaneous and mucocutaneous forms, that is Leishmania brasiliensis and Leishmania mexicana, are treated with stibogluconate 20 mg per kilogram per day for 20 to 28 days. The drug may be administered by either the intravenous or intramuscular route. Therapy for all forms of leishmaniasis may be repeated. An alternative drug for the visceral form is amphotericin B, marketed as fungizone, or liposomal amphotericin B, marketed as Ambisome. Liposomal amphotericin B is also recommended for mucocutaneous and cutaneous forms. Pediatric patients receive the same dose as adults. See Appendix 113(1) for side effects of the drugs. Pentavalent antimony therapy combined with interferon gamma or liposomal amphotericin may be alternatives in refractory leishmaniasis. Other combination therapies and alternative agents for the various forms of leishmaniasis are discussed in detail by a number of authors. We will now discuss the evaluation of therapeutic outcomes. The presence of dead mastigotes in tissue and bone marrow, resolution of anemia and leukopenia, and disappearance of splenomegaly and hepatomegaly may be used as monitoring parameters for the disease. Travelers to endemic areas should use insect repellents and sleep in fine mesh netting to avoid exposure to the sandfly. No effective chemoprophylaxis against leishmaniasis is available. Pause the video and carefully scrutinize Table 113.5 summarizing the clinical presentation of South American trypanosomiasis before advancing to the next slide. Next we will discuss the American trypanosomiasis. Let's begin with its etiology. Two distinct forms of the genus Trypanosoma occur in humans. One is associated with African trypanosomiasis, sleeping sickness, and the other with American trypanosomiasis, Chagas disease. Trypanosoma bruce-I gambians and Trypanosoma bruce-I rhodesians are the causative organisms for African trypanosomiasis. In Chagas disease, the trypomastigote is found in the bloodstream, and an ovoid, unflagellated intracellular form is found in cardiac and other tissues. Trypanosoma cruzi is the agent that causes American trypanosomiasis. American trypanosomiasis is transmitted by a number of species of a reduviad bug, Triatoma infestans, Rodrium prolixus, that live in wall cracks of houses in rural areas of North, Central, and South America. The reduviad bug is infected by sucking blood from animals, e.g., opossums, dogs, and cats, or humans infected with circulating trypomastigotes, as shown in Table 113.5. In chronic disease, patients present with cardiomyopathy and heart failure. Electrocardiograms are usually abnormal, demonstrating extrasystoles, first-degree heart block, right bundle branch block, and other serious conduction disturbances. Degeneration of the autonomic ganglia in the smooth muscle of the esophagus and colon leads to uncoordinated peristalsis. The end result has been reported to be megasyndromes of affected organs. Penetration of central nervous system results in meningoencephalitis, strokes, seizures, and focal paralysis. A history to verify the possible exposure to Trypanosoma cruzi should be an important initial diagnostic workup. Recovery of Trypanosoma cruzi is definitive, but this is not always possible, especially in chronic disease. Positive serologic tests using indirect hemagglutination tests, ELISA, Chagas-Air, Abbott Labs, and a complement fixation, abbreviated as CF, test are diagnostic. The CDC has used PCR to diagnose Trypanosoma cruzi. Specimens may be sent to the CDC for testing. False positive reactions are seen, especially in those exposed to leishmaniasis, syphilis, or malaria. Next we will discuss the treatment of American trypanosomiasis. Let's begin with the desired outcome. The primary goal of drug therapy in trypanosomiasis is to reduce the duration and severity of the illness and possibly to decrease mortality. We will now look at the pharmacologic therapy. The drugs that have been used to treat Trypanosoma cruzi infections include nifurtimox, marketed as Lampit, Bayer 2502, and benznidazole, marketed as Rochagan. However, it has been suggested that benznidazole and related compounds may not be safe treatment for Trypanosoma cruzi. Oral nifurtimox is available from the CDC, whereas benznidazole is only available in Brazil. The adult dose of nifurtimox is 8 to 10 mg per kilogram per day in divided doses for 120 days. Because pediatric patients tolerate the drug better than adults, the dose for children aged 1 to 10 years is 15 to 20 mg per kilogram per day, and for children aged 11 to 16 years it is 12.5 to 15 mg per kilogram per day in divided doses. Symptomatic treatment for heart failure includes digitalis and diuretics. The gastrointestinal complications, however, may require surgical revisions and reconstruction. Next we will discuss the evaluation of therapeutic outcomes. American trypanosomiasis, that is Chagas disease, which is endemic in all Latin American countries, can be transmitted congenitally, by blood transfusion, and by organ transplantation. Treatment with nifurtimox of the acute phase, i.e., fever, malaise, edema of face, generalized lymphadenopathy, and hepatosplenomegaly, produces between 50% and 75% cure rates. Treatment of chronic infection with nifurtimox is not recommended. It is essential to identify Trypanosoma cruzi infected patients by serology and to monitor the cardiovascular status of these patients by electrocardiogram periodically. The congestive failure of cardiomyopathic Chagas disease is treated the same way as cardiomyopathies from other causes. Next we will discuss helminthic diseases. Most intestinal helminthic infections may not be associated with clearly defined manifestation of disease, but they can cause significant pathology. One factor that determines the pathogenicity of helminths is their population density. Light infections may be fairly well tolerated, whereas high populations of intestinal helminths can result in predictable disease presentations. In the United States, these infections are seen most frequently in recent immigrants from Southeast Asia, the Caribbean, Mexico, and Central America. There is a higher incidence of helminthic infections in the southern states. Other populations that have a high risk of infestation include institutionalized patients, both young and elderly, preschool children in daycare centers, residents of Indian reservations, and homosexual individuals. Certain conditions and drugs, fever, corticosteroids, and anesthesia can cause atypical localization of worms. Immunocompromised hosts can be overwhelmed by some helminthic infections, such as strongyloidiasis. We will now look at nematodes. Let's begin with hookworm disease. This is an infection of the small intestine caused by either Ancylostoma duodenale or Necator americanus. Necator americanus is found in the southeastern United States, where the temperature and humidity provide the proper environment. Ancylostoma is seen rarely in the United States. The life cycles of both species of hookworm are similar. The adult worms live in the small intestine attached to the mucosa. The females liberate eggs, which are eliminated in the feces and develop into larvae. Infective larvae enter the host in contaminated food or water or penetrate the skin, where a papular eruption with localized edema and erythema can result. In the small intestine, where the adult worm lives attached to the mucosa, injury is usually caused by mechanical and lytic destruction of tissue. The loss of blood can lead to anemia and hypoproteinemia. Stool should be examined for eggs and the rhabditiform larvae. Eosinophilia, 30% to 60%, is present in patients with chronic infection. Next we will discuss the treatment of hookworm disease. Mebendazole, marketed as Vermox, an oral synthetic benzimidazole, is the agent of first choice. It is also effective against ascariasis, enterobiasis, and trichoriasis. The adult dose for treatment of hookworm infestation is 100 mg twice daily for 3 days. Pediatric patients older than 2 years of age should receive the same dose as adults. We will now look at ascariasis. Ascariasis is caused by the giant roundworm Ascaris lumbricoides. Female worms range from 20 to 35 centimeters in length. The worm is found worldwide but more commonly in areas where sanitation is poor. In the United States, endemic areas include southeastern parts of the Appalachian Range and the Gulf Coast states. Approximately 4 million people in the United States have ascariasis. Next we will look at the clinical manifestations. During migration of the larvae through the lungs, patients can present with pneumonitis, fever, cough, eosinophilia, and pulmonary infiltrates. Other symptoms of ascariasis include abdominal discomfort, abdominal obstruction, vomiting, and appendicitis. Diagnosis is made by demonstrating the characteristic egg in the stool. Next we will discuss the treatment of ascariasis. In both adults and pediatric patients older than 2 years of age, the treatment for ascariasis is mebendazole, marketed as Vermox, 100 mg twice daily for 3 days. An alternative drug for ascariasis is pyrantel pamoate, marketed as Antiminth. We will now discuss enterobiasis. Enterobiasis, or pinworm infection, is caused by Enterobius vermicularis. The pinworm is a small, thread-like, spindle-shaped worm about 1 centimeter in length. It is the most widely distributed helminthic infection in the world. There are estimated to be 42 million cases in the United States. The majority of those infected are children. There are no significant pathologic changes with the infection. The most common problem is cutaneous irritation in the perianal region, made by the migrating females or the presence of eggs. The intense pruritus and scratching can cause dermatitis and secondary bacterial infections. In children, the itching can cause loss of sleep and restlessness. The most effective method of diagnosing pinworm infections is by the use of perianal swab using adhesive Scotch tape. The Scotch tape, which is applied to the perianal region with a tongue depressor, is examined microscopically for eggs. Next we will discuss the treatment of enterobiasis. Helminthic drugs are used to eradicate or reduce the parasitic load in patients. The common agents for treatment include pyrantel pamoate, mebendazole, or albendazole, marketed as Zentel. The dose of pyrantel pamoate is 11 mg per kilogram, to a maximum dose of 1 gram, as a single dose that can be repeated in 2 weeks. The dose of mebendazole for adults and children older than 2 years of age is 100 mg as a single dose. This may be repeated in 2 weeks. The dose of albendazole for adults and children older than 2 years of age is 400 mg, and this dose should be repeated in 2 weeks. Following treatment, all bedding and underclothes should be sterilized by steaming or washing in the hot water cycle of a regular washing machine. This will eradicate the eggs. Bathroom rugs and toilet accessories also should be cleaned in a similar way. Next we will look at evaluation of therapeutic outcome. Let's begin with nematodes. Morbidity and disease with intestinal nematodes are related to the intensity of infection or worm burden. Subjects with transient exposure have less severe disease. The major adverse effects of intestinal nematodes are malnutrition, fatigue, and diminished work capacity. Treatment with anti-helminthic agents results in complete eradication and significant change in the well-being of patients. Unlike other nematodes, strongyloidiasis can perpetuate itself by autoinfection, and under immunosuppression, the filariform can invade various organs, e.g., lungs, central nervous system, and the like, to produce disseminated infection that can be fatal. We will now look at ectoparasites. A parasite that lives on the outside the body of the host is called an ectoparasite. Approximately 6 to 12 million people become infested with pediculosis yearly in the United States. Pediculosis usually is associated with poor personal hygiene, and infections are passed from person to person through social and sexual contact. The three types of human lice belong to two genera, Pediculus, including the head and body lice, and Phathyrus, with only one species, the crab louse. The human louse is detectable to the human naked eye and measures approximately 2 to 3 mm in length. We will now look at lice. The two species that belong to this group include Pediculus humanus capitis, that is the head louse, and Pediculus humanus corporus, that is the body louse. Female lice deposit eggs on the hair. The eggs, or nits, remain firmly attached to the hair, and in about 10 days, the lice hatch to form nymphs, which mature in 2 weeks. Using both their piercing mouthparts and a pumping device, the larvae and adults feed on the blood of the host. The body louse and head louse are essentially identical, although they live on different parts of the body. Unlike the head louse, which lives on the hair, the body louse is more frequently found on clothing of the infected host. Pubic or crab lice are found on the hairs around the genitals, although they can occur in other areas of the body, e.g., eyelashes, beards, and axillae. Patients usually complain of severe pruritus from papular lesions produced by the bite of the louse. Hypersensitivity to foreign material injected by the lice can produce macular swellings and occasionally can lead to secondary bacterial infections. Next we will discuss the treatment of lice. The goal of therapy is to eradicate the causative organisms and provide symptomatic relief to patients. The agent of choice for all three infections, body, head, and crab lice, is 1% permethrin, marketed as Nix. Permethrin is a derivative of the flowers of the plant Chrysanthemum cinerarifolium. The term pyrethrin is usually applied to several esters of chrysanthemic acid and pyrethric acid. Permethrin has both pediculocidal and ovicidal activity against Pediculus humanus var. Capitis. The cure rate is reported to be in the range of 90% to 97%. Individuals who have a history of ragweed or chrysanthemum allergy should use this compound with caution. The side effects reported with permethrin products include itching, burning, stinging, and tingling. Permethrin 1% is applied to the scalp after the hair has been dried following a shampooing. The scalp should be saturated with permethrin liquid, and a towel should be wrapped around the scalp to allow the application to stay on for 10 minutes. The hair then should be rinsed off. A cream rinse of permethrin 1%, marketed as Nix Cream Rinse, is also available. To ensure complete eradication, especially of newly hatched lice, it may be necessary to repeat the application. Recent reports have suggested increasing lice resistance to permethrin 1%. An alternative preparation for lice is 0.5% malathion, marketed as Ovide, which is very effective. To ensure complete eradication of lice infestation, the malathion application should be left on the scalp for about 90 minutes. For the relief of pruritus, a soothing lotion of calamine liniment or lotion with 0.1% menthol may be used. Other members of the family or sexual partners also should be treated. All bedding and clothes should be sterilized by boiling or washing in the hot water cycle of the washing machine to avoid reinfections. Seams of clothes should be examined to verify that all organisms are eradicated. An ocular lubricant, e.g., Lacry Lube SOP, applied twice daily may be used to remove crab louse infection of the eyelids. Next we will discuss scabies. Scabies is caused by the itch mite Sarcoptes scabiei, which affects both humans and animals. Mange in domestic animals is caused by the same organism. Infection usually affects the interdigital and popliteal folds, axillary folds, the umbilicus, and the scrotum. We will now look at the clinical presentation of scabies. Patients will complain of severe itching and an inability to sleep and may have excoriations in the interdigital web spaces, wrists, elbows, buttocks, groin, and scalp. Excoriations may lead to secondary bacterial infections. The diagnosis is made by looking for burrows formed by the mite and taking skin scrapings, which will demonstrate the mite on a wet mount. Lastly, we will discuss the treatment of scabies. Because these infections cause a great deal of discomfort and distress to patients and families, the goals of therapy are to eradicate the infestations rapidly, to institute symptomatic treatment, and to provide counseling and reassurance. The treatment of choice is permethrin 5%, marketed as Elamite cream. To initiate the treatment, the skin should be scrubbed thoroughly in a warm soapy bath using a soft brush to remove all scabs. The lotion is then applied to the whole body, avoiding the face, mucous membranes, and eyes. The application should be left on for 8 to 14 hours before bathing. A single application eradicates 97% of scabies in subjects. All close contacts should be checked and treated appropriately. Other agents used to treat scabies are crotamyton 10%, marketed as Urax, and oral ivermectin, marketed as Stromectil, 200 micrograms per kilogram once. These should be used in patients who have hypersensitivity to permethrin preparations. Topical corticosteroids and antihistamines may be used to decrease pruritus. Permethrin 1% to 5% for pediculosis and scabies is the preferred agent and remains the safest agent, especially in infants and children. One application of permethrin is consistently effective in eradicating more than 90% of all infections. However, pruritus may persist for 2 to 4 weeks because of the remnants of mite parts in the skin. Thank you.